Good afternoon, and thank you for attending Theralase Technology Inc.'s annual general and special meeting of shareholders. My name is Matthew Perriton, and we're Investor Relations Manager at Theralase. It's a pleasure to welcome our shareholders and stakeholders as we begin the next portion of today's session. I'd also like to welcome our online participants who have joined us now that the formal portion of the meeting has concluded. To begin, I'll be presenting the Theralase corporate presentation, which will provide a comprehensive overview of our business, recent progress, and strategic priorities moving forward. Theralase launched 30 years ago as a medical device company, selling cool laser therapy devices to medical practitioners for the elimination of pain. We still operated this division, generating about $1 to $2 million per year in revenue. We plan to grow this division in 2025-26 with a few innovative products. 20 years ago, we pivoted to a pharmaceutical company focused on the destruction of numerous cancers, bacteria, and viruses using light-activated small molecules. This presentation may include forward-looking statements. Over the last 20 years, the company has focused its research and development activities on the commercialization of small molecules that can localize to cancer cells and, when light-activated, destroy them, leaving healthy cells intact. Our primary asset is for non-muscle invasive bladder cancer, currently under late-stage development in a Phase 2 registrational clinical study. Theralase plans to commercialize this technology internationally upon successful approval. In 2026, Theralase plans to commercialize a Phase 1/2 clinical study for the herpes simplex virus that causes cold sores. In 2026, Theralase plans to commence a Phase 1/2 clinical study for glioblastoma multiforme, a deadly form of brain cancer, also non-small cell lung cancer, muscle-invasive bladder cancer, pancreatic cancer, and colorectal cancer. We have a strong senior management team and work with world-class teaching hospitals. Our technology is protected by international patents, with 29 issued patents and 17 patents pending, covering the major economies of the world. Theralase holds numerous international patents protecting both our small molecule, Ruvidar, and our emitter detector assembly, used to activate the drug intravesically for bladder cancer. Expiry on base patents vary from 2033 to 2036, with the Hatch-Waxman Act able to extend these patents upon FDA approval for an additional 5 years, up to 2038 to 2041. The diagrams to the left are chemical representations of Ruvidar, our lead drug. Ruvidar has been specifically designed to hunt and destroy solid core tumors such as bladder, brain, lung, and breast cancers. Theralase has researched and developed this drug over the last decade, and it is manufactured in commercial facilities. To demonstrate the potency of the drug, only half a gram is required to effectively destroy bladder cancer. Therefore, a kilo of drug can effectively treat 2,000 patients. Only micrograms are required to treat cold sores. Therefore, a kilo of drug could literally treat millions of patients. Theralase has commercialized its TLC-2000 cool laser therapy system and plans to commercialize various other laser systems for both pain management and blood-based cancers over the next few years. In the summer of 2025, one of Theralase's strategic objectives is to complete enrollment in the bladder cancer clinical study by enrolling and treating an additional 8 patients. In 2026, we plan to complete the follow-up of the clinical study and submit the clinical data to Health Canada and the FDA for marketing approval. Theralase has numerous other cancer clinical indications ready for clinical study. Pending completion of good laboratory practice toxicology analysis, the company will commence Phase 1/2 clinical studies in 2026. What is cancer? Cancer cells are normal cells that have lost their ability to die due to DNA damage either by environmental or genetic factors, making them difficult to kill. By not dying, cancer cells continue to multiply, leading to tumors, and if not destroyed, in a majority of cases, death. We each have approximately 30 trillion cells in our body, made up of over 200 different types. There are more than 100 different types of known cancer. All cells require iron to grow, and since cancer cells have a higher growth rate than healthy cells, they require substantially more iron. Theralase exploits this weakness in cancer cells to target their destruction. Theralase's lead small molecule is a ruthenium-based drug called Ruvidar that binds with the naturally occurring protein called transferrin. Transferrin is used to transfer molecule iron to every cell in our body. Cancer cells require large amounts of iron and as a result have significantly more transferrin receptors than normal cells. Theralase has discovered and patented that unique characteristic that transferrin does not distinguish between iron and a ruthenium-based drug, as they both are transitional 8 metals. Cancer cells thus absorb Ruvidar and when light activated destroy the cancer cell from inside out. Non-muscle invasive bladder cancer. Bladder cancer is the 9th most common cancer in the world, 4th in men. There are 2 main types: non-muscle invasive, confined to the inner layers of the bladder, and muscle invasive, which invades the detrusor muscle. There are over 600,000 new cases of bladder cancer diagnosed in the world annually, strongly linked to smoking. Traditionally, bladder cancer has been known as an older, white male disease, but in recent years, demographics have been shifting into a much younger population. Individuals as young as 20 years of age have been diagnosed with bladder cancer, believed to be the result of an increase in adolescent vaping. The picture on the left shows a diseased bladder with carcinoma in situ that was absorbed by Ruvidar, the orange color. This picture has demonstrated why carcinoma in situ is not easily resected, as it can be easily spread all over the entire bladder wall. The second picture demonstrates Ruvidar absorbed into the bladder cancer cells, with the outline of the bladder cancer cell denoted by the faint red line, and Ruvidar fluorescing in bright pink magenta color. The third picture shows the fiber optics of the green laser system used to activate Ruvidar. The fourth picture shows a healthy bladder wall after successful bladder cancer destruction. Bladder cancer is traditionally known as an older white male disease, which is true for our patient population. However, that demographic of this disease is changing, mainly due to the prevalence of vaping among the younger generation, with patients as young as 20 years of age being diagnosed with bladder cancer. The clinical study design provides a primary study procedure at day 0 and provides up to 2 additional reinduction study procedures if the patient fails to achieve a complete response. These are some of the world-class institutions that the company works with in the completion of the clinical study. To date, 82 patients have been enrolled and treated in the Phase 2 clinical study. For the primary objective, 62% of patients treated have demonstrated a complete response, and 70% a total response. This includes patients who have an indeterminate response, which is no disease in their bladder, but cancer cells detected in their urine. For the secondary objective, 42% of patients have demonstrated a duration of their complete response for 15 months, surpassing the 30% guideline. For the tertiary objective, no patients have demonstrated any serious adverse events directly related to the study drug or the study device. In the extended follow-up, 23% of patients have sustained a complete response for 2 years, 21% for 3 years, and incredibly, 1 patient has sustained complete response for 7 years and ongoing. There are 4 drugs which are currently FDA approved. Starting at the bottom of the page, valrubicin has been approved for over 40 years. However, it is not widely used by the uro-oncology community due to its poor duration of efficacy. Keytruda was approved in January 2020, but due to side effects and being applicable to only a small subset of patients, it is not widely prescribed by the uro-oncology community. Astrologin was approved in May 2023. However, although showing a durable response, it is contraindicated for patients who are immunosuppressed or immunodeficient. N803 has been combined with the standard of care BCG and was FDA approved in May 2024. with 58.3% response in 1 year, 39.6% response in 2 years, and 22.9% duration of response at 3 years. It has a strong duration of response. However, most uro-oncologists associate that response with BCG and not with N803. These are the 4 main drugs which are currently under clinical evaluation. Starting at the bottom, DATA is a non-viral gene therapy in early stage phase 2 clinical evaluation. Next, slow release intravesical chemotherapy demonstrates strong initial efficacy, but this quickly diminishes over time. Past clinical research has shown that gemcitabine has little impact on the risk of progression of bladder cancer. Next is Credo, which has demonstrated strong initial efficacy and durable response. However, its use is limited to patients who exhibit retinoblastoma negative protein, which is approximately 25% of the CIS population. In addition, due to its complexity, it is not readily adopted by most uro-oncology practitioners. Theralase has demonstrated strong initial efficacy and has a strong duration of response at 42% at 1 year, 23% at 2 years, and 21% at 3 years, based on interim clinical data, with more data still pending. This is even more compelling clinical data given the fact that a majority of patients only received one treatment and there have been no serious adverse events associated directly with a study drug or a study device. Next is herpes simplex virus. There are hundreds of known strains of herpes simplex virus, but predominantly only 8 strains affect humans. Of these 8 strains, there are 2 that are more prevalent in humans, specifically herpes simplex virus 1 and 2. HSV1 is known to cause labial herpes lesions, commonly known as cold sores. HSV2 is known to cause genital herpes lesions. For individuals aged 15 to 50, 64% of the world's population are estimated to have HSV1, representing an astonishing 3.8 billion individuals worldwide that suffer from cold sores. This is a very large target market, representing the majority of the world's population. The mechanism of action of Ruvidar inactivating HSV1 is complex, but in simplified terms, Theralase's lead small molecule, a ruthenium-based drug called Ruvidar, is positively charged. And glycoproteins on the spike proteins of the HSV1 virus are negatively charged, as are the heparin sulfate receptors on the epithelial cells on the skin's surface, which is their target. Ruvidar is able to block both the glicoproteins on the HSV1 virus, preventing it from binding to the skin cells, as well as blocking infected skin cells, preventing release of their virins, which lead to faster healing of the cold sore lesion. HSV1 is the most prevalent virus affecting the world's population, with an estimated 3.8 billion people aged 15 to 50 afflicted by it. The global market for cold sores treatment is estimated to be 2.8 billion in 2024, ballooning to 4.7 billion by 2033. North America has the largest share of the world market with an estimated 37.1 afflicted individuals. This presents a unique opportunity for Theralase as we plan to focus our development efforts on the Canadian and US markets. Preclinical research. The figure demonstrates comparison of Ruvidar versus encyclovir when added to cells infected with HSV1 24 hours post-infection. As can be seen, increasing the dose of Ruvidar increases the inactivation of HSV1. However, the same is not true with encyclovir, which regardless of dose demonstrates that there is no appreciable difference in inactivation. The picture demonstrates the before and after effect of Ruvidar in a mouse model infected with HSV1. As can be seen, once daily treatments of Ruvidar for 4 days was able to completely inactivate HSV1 and heal the HSV1 lesion. The picture above demonstrates HSV1 lesions 1 day post-infection using various treatment methodologies. On the far left is a HSV1 lesion with no treatment. Beside that treatment is encyclovir, the leading prescription medicine for cold sores. Next is treatment for the top-selling over-the-counter treatment Abreva. Lastly is treatment with Ruvidar. As can be readily observed, Ruvidar is by far the most effective treatment of either of the top-selling prescription or over-the-counter drugs. Remarkably, Ruvidar need only one applied treatment per day for these results versus 5 times daily for the other treatments. The standard of care prescription treatment for HSV-1 is a drug approved for medical use in 1981 known as acyclovir, manufactured by GlaxoSmithKline, which was originally Burroughs Wellcome. Its mechanism of action lies in decreasing the production of the virus's DNA, hence lessening the length of time of the infection. It is available in a topical form known as Zovirax. Unfortunately, when taken orally, it lacks bioavailability. Hence, to overcome this issue, 2 different derivatives of encyclovir have been developed, specifically valciclovir and famciclovir, improving bioavailability. In addition, there's a topical cream called penciclovir. Acyclovir and all its various forms work using the same mechanism of action. For over-the-counter drugs, the leading is again GlaxoSmithKline with 71.1% of the U.S. market share for Abreva, a long-chain alcohol. Rounding out the list is Sitavig, a tablet that is placed in the mouth and allowed to dissolve over time. For HSV non-approved drugs, treatments that are under research and development include Theralase's HEX treatment and Pritlivir. HEX is being developed for over-the-counter use, which is $1 billion market in the United States alone. Pritlivir is currently being evaluated clinically, however, efficacy of treatment remains low. New cancer indications. GBM preclinical research. As an example of the effectiveness of radiation-activated Rutherrin delivered intravenously to human brain cancer cells, low-dose radiation is able to destroy over 95% of the brain cancer cells in a single treatment. Non-small cell lung cancer preclinical research. As illustrated, there is a significant delay in tumor progression in mice treated with X-ray activated Rutherrin versus radiation alone. Mice treated with X-ray activated Rutherrin demonstrated that the tumor is regressing over time. Muscle invasive bladder cancer preclinical research. As illustrated, Rutherrin is able to completely destroy muscle invasive bladder cancer without affecting the healthy bladder muscle wall. Leukemia, lymphoma, myeloma, preclinical research. As illustrated in the lymphoma mouse model, the combination of radiated activated Rutherrin, emmetforin, was able to completely destroy lymphoma. Regulatory timelines. The main objective of the company is to complete enrollment in the Phase 2 clinical study in the summer of 2025. This will allow submission of a complete clinical data set to Health Canada and the FDA in September of 2026, with the goal of marketing approval by early 2027. Regulatory timeline of HSV-1. The company plans to complete formulation in the summer of 2025, with GLP tox completed by the end of the year. Next will be Phase 1/2 adaptive clinical study, due for completion by mid-2026, followed by a Phase 3 registration clinical study, due for completion in early 2027. This should allow submission of complete clinical data set to Health Canada and the FDA in mid-2027, with the goal of marketing approval by the end of 2027. Regulatory timeline for glioblastoma, multiforme, non-small cell lung cancer, pancreatic cancer, colorectal cancer. The company has completed formulation and plans to complete GLP tox by year-end. Next will be multiple Phase 1/2 adaptive clinical studies due for completion by end of 2027, followed by multiple Phase 3 registrational clinical studies due for completion by end of 2029. This should allow submission for complete clinical data sets to Health Canada and the FDA in early 2030, with the goal of marketing approval by mid-2030. Non-muscle invasive bladder cancer investment highlights. Theralase is focused on commercializing the next standard of care for bladder cancer, the ninth most common cancer in the world, fourth in men. Theralase offers a patented, safe, and effective treatment that can be administered to a patient in a few hours, achieving cancer-free status in 62% of the patients treated after just one treatment, and maintaining an efficacy of 42% of patients treated at 15 months. The interim clinical data is world-class and has strong duration of response at 1, 2, and 3 years. Theralase plans to commercialize a topical treatment for HSV-1 in late 2027. Theralase offers a patented, safe, and effective treatment that can be self-administered by patients for cold sore lesions that has been shown to be significantly more effective than both the prescription and over-the-counter standards of care in preclinical models. Other cancer indications investment highlights. Theralase plans to commercialize technologies for numerous cancer indications in 2030. Theralase offers a patented, safe, and effective treatment as demonstrated in preclinical models that would allow Theralase access to a global market valued at $286 billion US in 2030 upon commercial approval. The company has a stock price of 18.5 cents and a market cap of $46.4 million. Insider ownership is approximately 12.75% fully diluted. Thank you for your time. I will now ask Roger to come to the front to address any questions that shareholders may have that relate to publicly available information.
as okay. So if you look at comparable companies, so for US listing, there's really the New York Stock Exchange and there's NASDAQ. NASDAQ would be a better choice. Why? Because there's more technical companies there. There's more comparables there. But New York Stock Exchange is another opportunity. So we believe the direction is we've traditionally tried to stay on TSXV, go to TSX at some point, the big board in Canada, and then do what's called an MJDS, multi-jurisdictional something listing. In that case, you can put a wrap on your financials and you can trade in the US on NASDAQ. It's a lot easier to do it, okay? Unfortunately, there's rules to the game. You have to have a $75 million US capital base to do that. So if you don't have that, you've got to do something else. So what the company's looked at is we've never been a big fan of doing reverse splits. Why? 95% of the time, it doesn't work. Companies see it as, or investors see it as blood in the water. And I can give you numerous examples of companies that have done reverse splits only to end up back at their stock price and end up really just hurting the shareholders that have supported the company. Now, what we're looking at is a new direction called ADRs, American Deposit Receipts. I mean, ADRs work for foreign companies in the sense that you can take your stock, bundle it. My example is typically if our share is a match, then we put it into a match box with 20 other matches or 50 other matches. Under an ADR, you can have what's called ADSs, American Deposit Shares. So it wouldn't affect shareholders in Canada. What would it allow is that the stock trades at a multiple in the US by combining the shares. So or just so I can work out the math, let's say there's 250 million shares out, okay? Let's say that the company did a 10-for-1 ADR. There would be 25 million ADRs trading at, let's say our stock is 20 cents, trading at $2. Now, the requirements to meet NASDAQ and New York Stock Exchange can vary from $2 to $3 to $4, depending on whether you're going into global markets, select markets, capital markets. There's all these different levels, but typically it's around a $4 stock US. So the direction of the company would be we've looked for funds in Canada repeatedly. We have not been successful. So we believe that those funds are going to have to come from the US. So in order to do that, we plan to do an ADR, which would combine the stock at the time when we do it, and then be able to trade those ADRs on the US exchange, whatever exchange that may be, and then be able to, if we're successful in what we set out to do, which are all these plethora of cancers that we've talked about, we'd be able to dissolve the ADR and just trade as a normal share, would be the direction. Is that a comprehensive response?
Yeah, just to follow up a slightly different angle. If the money is one thing, and obviously finding the money, you have to go wherever you have to go. But we're in a knowledge business, and the pharma companies, whether the biggest, the mediums, or even the smallest, are globally out there. And certainly our findings, our research should interest many of them, or and some of them. How much are we looking for partnerships? By indication, by region, by any other mechanism to find money that way?
Well, I think you'd have to go back into history, and pharmaceutical companies traditionally had their own staff. They had 75,000, 100,000, 125,000 employees, where a majority of those were PhDs that worked on developing new drugs. What happened to pharma probably 25 years ago was they found that they put a lot of money into developing drugs, and then they found that some of them weren't successful. The one example I think of is one big pharma, which I won't name, put in 900 million US into a drug. all the way to phase 3, and then walked away from it. So they walked away from almost $1 billion. So what they decided to do en masse is we're gonna fire all those guys, and we're gonna put them on the street, and we're only gonna look at smaller companies like Theralays, and we're only gonna pick the winners. That way, if you fail, we don't care, it didn't cost us anything. So they look at the winners, and what Theralays has demonstrated with its phase 2 clinical study in bladder cancer, we are one of the winners, okay? We are right in the sweet spot of the numbers. Are we dramatically higher than everyone? No. Are we dramatically lower? No. Are we in certainly a good space? Yes. We have advantages. One, our drug is a small molecule, which has a very long shelf life. We've shown 10 years, okay? A lot of the other drugs are BLA, biologics, which mean that they have to be kept at negative 80 degrees Celsius. So there's a whole cold chain associated with it. 2, there's a lot of complexity to mixing their drugs. Ours is pretty simple. It's a lyophilized, sterilized powder, like freeze-dried coffee, that you just pour water in and you've got coffee. You pour sterile water in our drug, you have Ruvidar, okay? So for that, we have a lot of advantages. The other thing is we're one treatment. So a lot of the other competitors, they have to treat you every week, every 2 weeks, every month, for 2 years, 3 years, if you can handle that therapy. Ours is one and done. So we have a lot of advantages for that. So as far as pharmaceutical companies go, back to your original question, they're looking at later stage companies. So companies that are on their way to an FDA approval or have achieved an FDA approval. As Matt outlined in his presentation, we're looking to complete enrollment. We've completed 82 patients to date. Our statistical analysis plan calls out 90. We are tracking those remaining 8 patients. We plan to complete them by the summer of 2025. That puts us on track for a complete data set by September 2026. At that point, we can do what's called a soft hard data log, confirm all the data, and we can submit what's called a NDA, or new drug application, for Health Canada and the FDA. On a priority review, that's 6 months to get it done. On a non-priority review, it's 10 months. So we're looking at first quarter, second quarter, 2027 for a full approval. The market in the US for bladder cancer is worth billions of dollars, okay? Being a player in there, we will have a slice of that pie. Are we gonna own the whole market? No. Are we gonna have a chunk of it? Sure, right? Because we have a number of advantages. And it's certainly something that, you know, is attractive to the uro-oncologists that prescribe the treatments, for the patients, especially the rural patients, who don't want to have to travel back and forth. Because as Matt stated, bladder cancer is traditionally an older white male disease, but it's also older white female. When you're older, you don't want to travel back and forth to the hospital. You'd rather go in, have a treatment, have it done, cancer's gone, I'm a happy camper. So there's a number of advantages. So as far as partnering, I think that those opportunities are increasing as we get closer to completing the phase 2 clinical study. As we embark with Dr. Mendel's research in glioblastoma multiforme, non-small cell lung cancer, pancreatic cancer, muscle invasive cancer, colorectal cancer, and then into the blood cancers, as well as herpes simplex virus, there's certainly opportunities. With capital behind this, we'll be able to advance those much faster and get them to market much faster and be able to partner them much faster. So in answer to your question, yes, we are exploring many different avenues with pharmaceutical companies, and they're in various stages, from beginning to advance. So once that becomes material, then the board of directors will announce it. Thank you. Any other question? You in the back, you had a question?
No, I really was being facetious, and when you said the stock value was 18 cents, well, it's gone to 20 cents or whatever and I thought I was gonna help with my retirement. So I'm wondering, why it's at 18 cents? It sounds good. Are you into too many offshoots that you're spread too thin? Why would it hang in at that price?
Well, I can't really speak to shareholders and what they feel, but I think generally, when you look at a company from a market cap perspective. So the market cap of the company is around $50 million, okay? There's a lot of companies that would envy having a $50 million market cap. The reason the stock's lower is we have more shares in it. We have about 250 million shares. But if you look at a company with our technology and what we're able to do, I don't think that that's too many shares. I think what the company needs is either one of two things to drive the stock price. One, capital, in order to execute on its direction and its world-class technology, or two, partnerships. Other companies that bring to the table distribution, regulatory, commercialization. If one of those events happens, then I think it'll lead to stock appreciation.
Do you have enough people that can do the investigation as required? Because you've got to go in depth.
Well, I believe that we are a small company, but I believe that we are a talent. I believe the skill sets of the people employed are very strong. So we have a lot of smart people. We don't have lots of people. We don't have the burn rate though of some companies. I know one of my competitors, or our competitors, because we're all shareholders, burns around $500 million a year. We burn less than 5. Okay, and our technologies are not that different in the sense that, you know, we're able to deliver as good a result or better than they. So I think that the opportunity is you've taken a company, and I was just telling someone earlier, it was Ross, that I founded this company July 13th, 1995, 30 years ago. So it takes a long time to build a company. So it's taken me 30 years. Maybe if we had somebody smarter, maybe they could have done it in 10. But yeah, we didn't. We had me. So it took me about 30 years, but I think we've delivered a lot on what we've been able to achieve with a world-class drug and a world-class opportunity. And I think that will come to fruition as the year goes on. So I would hold on tight, strap your seatbelts in, and watch for the company's news. Any other questions? Oh, no.
In regards to the HSV treatment, is the end goal to be like it'll be a prescribed drug, or is it possible that it could be an over-the-counter?
We prefer where we're angling, and that's a good question. We're angling it as an over-the-counter drug. Why? Because you can sell a lot more of it. The problem with being over-the-counter is that the price that you generate from it is about 1/10. So a cyclovir is probably around $200 US for a prescription. A Breva is probably around $20 US. So we would angle it for over-the-counter use. That really is up to the FDA. We would angle it. Now, a cyclovir, which is the standard of care, they push to be over-the-counter. Now, the FDA formed a consortium of dermatologists and doctors, and they kind of said no, okay, that you can't go there. We're going to start off going for over-the-counter use. Now, it's really up to the regulators. So I think that the numbers would be the same. So if you sell 1 billion prescriptions, or over-the-counters at $20, or if you sell 100 million at $200, the net revenue is the same. Okay, so it really depends on, that's a regulator question. We would prefer over-the-counter, okay, but it may not be our decision. Yes, sir.
I'd like to know about the role that Health Canada is playing with the rates in terms of approvals.
Well, Health Canada is obviously the regulator for Canada. They do follow the FDA quite closely. So if you look at the guidelines of Health Canada, they do follow the FDA. For the bladder cancer technology, which is the stage we're at, Because they're not involved, Health Canada and FDA are not involved in preclinical work. It's only when you get to clinical. So when you jump across that chasm and you start treating people, you get involved. So with the bladder cancer asset, we have both an ITA, which is an investigational testing authorization for the device, and we also have a CTA, clinical trial authorization for the drug. For the FDA, we have a IND, investigational new drug. So in order to achieve that, you have to provide preclinical data, non-GLP toxicology data, GLP toxicology data. You have to provide an investigator's brochure, a clinical protocol. You have to provide principal investigators and their curriculum vitae that are associated with that. You have to provide informed consent forms. You have to provide case test report forms. So Health Canada has been involved in the entire process. So they're well aware of where the company is. Obviously, we have to remain in compliance with Health Canada or they'd shut the study down. You have to remain in compliance with the FDA or they'd shut the study down. So we're on good terms, to my knowledge, with Health Canada and the FDA. Did that answer your question? Are there any other questions? Lady in the back?
We have some here.
Oh, you have a
Yeah, of
question?
course. Let me just take a look here. So, sorry, I answered a few of them here. This is maybe on a treatment question. Do you want me to, we got glasses here.
All right, so we have one question. Can we increase the drug dosage and frequency of shots to improve the cancer destruction? I assume that this is related to bladder cancer. The answer is no, because you have a clinical protocol which is set. So the dosage of the drug, the delivery of the drug is set. If you wanted to modify that, you could. You could go to Health Canada, the FDA, and say, we want to change this, and we want to double our dose, and we want to double our treatments. However, they would say all clinical data collected to date is done. You can no longer compare them. So since we're so close to the end of a study, I would not recommend that.
We could carry on that one. Or this is more of a barring any regarding our funding situation about whether we're going to be doing a joint venture or any what our plans to do to raise funds in the meantime while we work towards a joint venture or a larger capital raise.
Well, I believe that if you look at the company's financial statements, which we approved today, it showed a loss of about $4.3 million. Okay, so you'd be looking at a little under $400,000 a month, probably about $350,000 a month. In order to go public in the US, process is about 4 months. Okay, so if you look at those numbers, you're going to need about $1.4 million. The company has been successful in raising non-brokered private placements. So we would continue that route, or we would look at debt financings. There's various debt mechanisms that are out there in order to get us across the line for a US listing.
Great. How much, here's this one here, it's BTD. You want to touch upon that? Just put an end to it.
Yeah.
And then we've got how much capital do we need for this one here?
Well, I think how much capital do you need for all planned expenditures to the end of 2027? How much for herpes only? Well, it depends on the stage of the treatment. So if you're doing GLP tox for both the systemic Rutherrin IV and also for a topical, which are 2 modes of administration, I think you're going to need at least $2.5 million for GLP tox. If you're running phase 1s, you're going to need at least $1 million per phase 1. Okay, to run a phase 1/2 may take $1 to $2 million. So I think if the company was in the end of 2027, so that would be 2.5 years. I think the company would need about $25 million.
This is for Michael, and we target some of these cancers earlier stages. I think it's kind of.
Well, again, if, you have to look at, if you're targeting a cancer, you'd have to look at what stage you're going at, what are the standards of care available? Because you can't deny a patient standard of care. So, you can't be first line therapy. So if a patient, God forbid, has cancer, they have chemo, they have radiation, they have surgery. You're gonna have to work around them because you're gonna have to deal with unmet needs in the sense that the patient had chemo, they had surgery, they had radiation, and it didn't work. So there's this group of patients that standard of care is not working with. Those are the ones you have to work with. You don't get to cherry pick your patients. So you'd have to work with Health Canada, work with the FDA to identify the unmet need. Where is the need for it? Because if a patient can get treated with a pill or an IV, why would you introduce your drug? Right? They're going to be treated effectively with another technology. So you have to look at the unmet need. Are there any other questions?
That's it for here.
Okay, any other questions from the floor?